Good morning, and thank you so much for that presentation. So I have two questions. The first is for Dr. Ogunro. The patient that had the surgery, the first surgery, the patient was only eyed and had the gut. And I think before surgery, I did see with correction 6-9 and first day post-op HM. It improved after 3 days, but I want to know why. Why did it drop to HM? Was it hyphema or not? Can I ask the second one? Or okay, the second question is for the patient you presented. Dr. Smith talked about giving the patient Duristar, and he did quite well. I'm wondering why you didn't consider it again as part of the treatment, and could that have been responsible for the cataract the patient had and needed to have cataract surgery? Because he didn't have cataracts before the intracameral and he had cataract after. So why didn't you even consider it after you took out the cataract? Why didn't you consider putting it back since the patient did very well while he was on it? No, the intracameral bimatoprost. Why didn't you consider it? Yeah.
Yes, I mentioned it that this patient had 10% hyphema and the hyphema which settled. And of course, the patient was told the reason that there's no problem. And hyphema is not unusual after GAD. Yeah. Thank you.
You know, I like the way you're thinking is the response to my question. First of all, if you know how to give an intracameral, you shouldn't develop a cataract from it because you won't touch the lens. And that Durysta usually stays in the anterior chamber in the inferior angle, and pretty much in most people stays in place. But back to your question and how you're thinking about this process is at any point in time, even though I'm not in the US now, I can say what I want, and I'm not speaking on behalf of anybody, we do repeat the Durysta injections. And at any point in time, just like you would introduce a drop, you can consider repeating a Durysta injection. So I think the mindset here is to realize that I have options. We didn't repeat it because we had choices and we just picked the next one. So it's being able to look at your choices and say, okay, at this point in time, I'm going to do this. All right.
Thank you, Max and Sas, for the presentation. My question is, can someone perform MIGS in a blind eye with elevated intraocular pressure? Then secondly, what determines the type of mix to select for a patient?
Those are excellent questions. The first thing is, generally speaking, we do not do intraocular surgery on an NLPI, generally speaking. So intraocular surgery, if you have a painful blind eye, we would do something like a CPC, which is not intraocular surgery. I have had patients who have had eyes that are painless, with blind, painless, with elevated intraocular pressure that have opted to do nothing. And I let them go. And I say, if that eye becomes painful, we will choose to do something about it. But generally, we do not do a mixed procedure on an eye that doesn't see. Now, in trying to decide which procedure to do, like you see, it's a real adventure. But some general guidelines. There are special situations where you can do a mixed procedure on an eye that has maybe chronic angle closure, not secondary angle closure, but open chronic angle closure where you do gonius saniculitis and you can do something like a GAT and take the lens out. But generally, you're looking for an angle that's open. If you're trying to do an angle-based procedure where you can identify the angle structures, understanding the patients, the basis for their glaucoma, the pathophysiology of their glaucoma is also helpful. Dr. Herndon inferred to doing this in patients who have secondary glaucoma, pseudoexfoliation. You know, remember the disease entity that's presented to you. Make sure you can actually see to achieve the goal. Make sure conjunctival scarring is not there. Look at the options that have been performed first, so you know how to move on to the next procedure. But we'll be at the wet lab, like I said, this afternoon, going over some of these procedures, and we'll be talking about when they will be best or most optimal.
also add that as the next question is readied, that a lot of the procedures have very similar outcomes. Okay, so a lot of it is, where is the aqueous going? If the aqueous is going through Schlemm's canal, those patients do about the same. All the, the stents, the otomies, the canaloplasties, they all do about the same. Your MIBS procedures, about the same. So you can think about these more in classes, and you can subcategorize incision, stenting, etc. Some of these choices are based on access. Some of these are based on comfort. Some of these are based on how much of the anatomy is visualizable, and surgeon comfort, right? So, but because they all kind of work similarly, you can, again, indeed choose your own adventure.
The other thing to remember is pick one thing in each category and know it well, and then you can expand your knowledge of the other procedures. So we have young surgeons who graduate in the US, and they don't learn how to graduate. And they ask me, how do you decide? Just that same question. I say, pick one. One stenting procedure, one tearing procedure, one suprachoroidal procedure, one subconjunctival filtration procedure, and you just do those first, make sure you're good, and then start adding all your things.
So,
cause of inflammation, you have PAS again. So what then do you do? If that is the only procedure you know how to do you advise repeating GAT?
Yeah, I did a bunch of patients. Patients, about 60 patients over the past 6 years, chronic angle closure, where I've done gonial synovial. I take their lens out, and then they get a GAT or a KDB. The patients tend to have to remain on pilocarpine, and I had reduction of meds from 3.5 to like 0.6 or something like that. Most of them over a 5-year period of time, with lowering of their intraocular pressure. The thing to remember in some of these patients is that their pathology is in the closure of the angle. Many times, the pathology in the trabecular meshwork may happen as a result of that PAS formation. So if you're able to bypass that, they tend to do really well. So the success for these patients is a little different from that patient with primary open angle glaucoma with long-term sort of disruption to meshwork and distal outflow reduction just because of pathology. So they will do well. Many of them do well. Success rate is high. But if you've worked on the angle before, whether it's open angle glaucoma or, chronic angle closure, you've done a GAT, I would not go back and repeat a GAT. I will think of subconjunctival filtration or suprachoroidal outflow surgery or trap tube, whatever.
so, okay. So, this has been a very good presentation, and I think it's so good to open up one's mind. However, I look at that patient, this patient we just talked about, and I can see that the patient had to go to theater about 3 to 4 times. Now that, for me, working here with no insurance for the patient, is something that will not really fly with many patients. And so the moment you're going back the second time, they're like, the eye is gone, kind of, yeah. And so we may not just need to change the paradigm, mind of the surgeons, but also of the patients and also of our working environment. And of course, we have to look at the economics of some of these things. Thank you.
I think that's a great point. And remember, one of the biases we have about taking patients to surgery is based on the surgeries that we had been doing, right? If it's a big deal to take someone to the theater and do a trabeculectomy or a GDD. It's not a big deal to put a stent in, right? So, but it's very easy to fall back on those old reservations and apply them to a new scenario. So we have to not only, to your point, we have to change our paradigm in terms of how we treat, but also our approach to all of this stuff. And patient education is a big part of it. So when I meet a patient for the first time, I tell them point blank, regardless of disease severity, there's a very good chance we're going to be doing surgery at some point. Okay. I don't tell them we're doing it tomorrow. I said, we're going to start with something small and we might go bigger. And I don't know where this journey goes, but your glaucoma will fight us every step of the way. And I'm going to fight as hard as I need to and no harder. And that might mean lasers, that might mean surgery, that might mean anything. So we have to set the agenda from the beginning.
So the one thing I want to use as an example here is the concept of SLT. Laser trabeculoplasty has been around for 40 years. Why are we just having that conversation? It's shameful that we're just having that conversation as people who provide eye care. The glaucoma laser trial was done at Wills, I don't know how many years ago, that showed that medications were just as good as laser trabeculoplasty. But now I think the reason why we're changing our mindset is not only because of the era we live in, the realization that doing laser trabeculoplasty has an effect on what we could possibly be doing in the future. The real crunch of it is that conversation changing the mindset, even in SLTs, amongst physicians in the US. We are coming to that place where we're comfortably saying it now that I will do an SLT first, but there is still some people out there who have a hard time having a laser conversation with their patients, me included up to a couple of years ago, maybe 2 years. Now, when I recommend an SLT to a patient, it is not a maybe we can do a laser. It is just like I would tell you, I'm going to put you on an eye drop. I tell you, we're going to do a laser trabeculoplasty. We're going to treat your drain to cause your natural outflow system to keep working as long as I can keep it working. That is what I say. I don't even use the word laser. But I had to change the mindset of the realization that I'm taking a patient to do a laser because we were taught. And the way we were trained to think was to do a laser after you had used a drop. You maybe do a laser after the second drop to prevent a third. And it's a mindset. So I've been able to overcome that mindset. You jump the hurdles. You have to, first of all, address yourself. Be assured in the care that you're providing. Then you can then talk to your patient. If your patient reads your conviction, then it's now I don't have patients saying, I just say, oh, we're going to do a laser. You're coming in 2 weeks and we'll do your other eye. We're going to keep your outflow. We don't talk about laser. Oh, where is it? It's in that room right there. And does it hurt? No, it doesn't. And you get a pamphlet and that's it. So it is also about not just the big things like taking a patient to surgery. I do Durysta in both eyes in the office. There are all these things that are now becoming the norm. We will all get there. We will all run this race at different paces, but we start with ourselves. Dr. Hendon, do you want to comment?
Mine is just mine is a comment, or maybe a follow-up. Maybe a follow-up on that interesting case presentation.
But it's a hypothetical.
Yeah. So I think it's really interesting that you wanted to do so many things, you know, as you went along. For us, 24 millimeters, yes, it's high. Maybe it's early glaucoma, and that's not really what we do or see or have the confidence to treat in these places. But my question is really, it's not even about SLT. SLT, why didn't you want to repeat it? That's number one. And I don't know if there's any publication to tell us how repeatable SLT is. When does it fail and when does it repeat? I know we have a study being done here in Bauchi. It's going to tell us the results very soon, but we need to know how often can we repeat and what intervals. And then secondly, you talk about your patients. Now, when your patients come to you, they stick to you, right? Because they have to, maybe their insurance and they're booked with your clinic. They have to stick with you. What happens with us is they go shopping from place to place because there's no obligation for them to stick with one doctor. And that's where we run into problems. If I see a patient with 24 millimeters of mercury and I say I'm going to do, okay, SLT is easy, they would accept it. But if I say I'm going to do a Zen or a hydrous implant or something, they want to find a second opinion.
Yeah, great. Great.
I have a comment from the online.
Paradigm shifts are not a new thing in medicine as a whole. I find it hard to think of a disease process that, especially a chronic disease, even things that are not chronic, that hasn't had a paradigm shift in the time since I have graduated. And it's actually up to us to recognize the paradigm shifts and shift with them. We have a debate coming later on, I think tomorrow, whether glaucoma is surgical or medical. I have my opinions about what I think it is. But if we, as physicians, don't adapt to what science tells us is changing, then we don't know what to tell our patients. Like she said, we don't have the conviction to tell our patients. So the first thing is to recognize that what we know today, in 10 years, we may be practicing different. So just get ready to move with what science shows us is the next thing. So that's the first thing. And I do respect the fact that the degree of, because my first practice was in Mississippi. That's when I learned to differentiate between a 0.95 cup and a 0.99 cup, and that there was a difference, right? So I do know when people come to you at the later stages of diseases, then your options are limited. But the more we push the idea that glaucoma is a lifelong disease, and that if you throw at patients your biggest guns first, then you are not left with a lot to offer them in the later stages of life. It doesn't matter what we do, that is going to fail and you need to do the next thing. So if you do the biggest surgery first, what are you going to do next? Everybody sort of needs to start so that they don't go doctor shopping. We're all telling them the same thing. You need to use your smaller guns first, then you go to the medium guns, then you go to the higher guns. It's a long, I have a company, it's called Longview. That's what I was thinking about. You can't just think about the short term. In glaucoma, you have to think, well, you're 45. Hopefully you live to 80. What do I do to keep you seen in all of that time? My traps are going to fail at the best in 10 years. How many more can I do?
So just to respond to Fatima's question, you can do an SLT. You can repeat SLTs. If your second SLT was responsive, it depends on how long it works for. I will repeat an SLT up to 3 times. If it works the second time, I will repeat it the third time. So you have to document in your chart the response to your SLTs. I document SLT effective. If at 6 weeks you come back, I got a pressure response, and we follow you again until you need your next SLT. You can stack them, you can do something else and come back and do them. That is why it's an adventure. That's that. There is a big clinical trial going on in the US. SLT is the nothing surgery. That's what I call it. It's not a big deal. It is the nothing surgery. It's a surgery that I will do 10 times on my eye because that's how I see it. So the next thing here is the shopping around. You're all in this room, and I hope this makes up a large community of the glaucoma specialists at least in the Southwestern region. If you know what the right thing to do and you communicate that to your colleagues, every time they go shopping, everybody will tell them the same thing. Let me ask a question in this room. How many times, or no matter where you go, let's put our hands up. If you had glaucoma, will they say you have to use an eye drop? If you have a glaucoma patient, no matter where they go, the way we practice in the past 10 years, no matter which doctor you go to, will they give you an eye drop? So if tomorrow our consensus says the way we treat a patient is this, and it has become what we do, that will also change. No matter where they go, they will get a message that, just like they would, saying you have to use an eye drop. But the change starts somewhere. And it starts in this room with the people who are here to hear why we have to make the change. It is a difficult society to deal with. People will travel, people will try, people will, sometimes people in America, they go get second, third opinions. If I refuse to do something because that's what they want, they will go somewhere else. I'm okay with that. But we need to do what is right by us and right by our patients.
I totally agree. I think we should have our own ethics, and the ethics are guided by preserving the patient's vision and quality of life. And what is the best way to do that? I'm not sitting here and saying we've solved it. I'm suggesting that we may have a better way than the previous way of doing it. And it's not a one size fits all solution. In fact, that's the beauty of this approach, is it is indeed individually tailored to the patient and their disease, their lot in life. What do they do for work? What is their ability to have time off? How, et cetera, et cetera. So many variables can be introduced. And to your point, absolutely patient. I mean, I can't tell you how many, most of my clinic patients are second and third opinions. People shop all the time. But uniformly, what I hear from patients who end up in my practice, and it might be some degree of self-selection, is having the conversation about the lifelong nature of the disease, the long view, as Lola mentioned, and our goals. What is our first principal goal? We want to keep you sighted, keep you comfortable, keep you happy for the rest of your life. One day longer than, I joke with my patients, I need your eyes working one day longer than the rest of you. That's it. Not two, that's extra credit. And if we outline how we're going to do that, the method of doing it, if patients don't like it, they can go elsewhere. That's fine. There's no shortage of glaucoma patients, right? But I think it is up to us to educate patients on what I would argue is sort of a better, more patient-centric practice pattern than we have been doing.
We talked about this, and you know what? I'm not here about it. I'm here about this. This is why we're here. We may have patient complaints. I don't know if you have an awareness. I will tell you a story about it. I am blind in one eye. Now, I have a story to tell. I'm sorry I'm taking up time. We came to Glaucoma. Is Dr. Chidima, are you here? Can you come tell this story? The story about the twin boys?
So get the pressure. Yeah, I would say don't think of it. I'll make one comment and then please share your story. We want to hear it. It's easy to think about how much does this lower the pressure? That's not probably the right way to think about it. No medication, no surgery takes you from, it's not this drop gives me 7.5 and this drop gives me 12 and this surgery gives me 14. No. Think more about where is the aqueous going and what is the resistance to flow in that pathway. And this is why we mentioned earlier, Schlemm's canal, what is the resistance to flow through the Schlemm's canal pathway? Episcleral venous pressure and distal outflow disease. What is the sort of collector channel disease and whatnot? So there is a floor. So the lowest you can typically get, the episcleral venous pressure, 8-9, right? We generally find that we are just a little bit above that because of this sort of whatever other intrinsic dysfunction. So I have patients, our 3 GAT patients from yesterday, what were their average pressure was 50 preoperatively on max meds, 50. And their average pressure today is 13, okay? So it's not about how much reduction, it's about to what pressure do you get? And with canal surgery, you can get to mid-teens. With a Zen, remember the resistance to the Zen is 7.5. So the lowest you can get is 7.5 plus subconjunctival resistance, episcleral fibrosis will raise that pressure to between 14 and 15, et cetera, et cetera. So it's better to think about the method of pressure reduction and as opposed to the starting pressure and where that aqueous is going.
And our discussion is about the campaign to let people know. I can't count the number of people who come and I just see them and they're blind. They're essentially blind. It's very discouraging. We have to change how our patients come in to see us. Unfortunately, that's how it is because people won't come. So our responsibility needs to go beyond. We've talked genetics. We've talked, Fatima has done excellent work in community outreach. We have to harness this to do better because it becomes important when the patient has an island and the pressure is 50, that you're trying to get a pressure of 10 and we're talking trabeculectomy. But what of all those people who are out there walking around trying to get to be that person who's blind in one eye with a pressure of 50 and an island that will show up in your clinic? We're going to leave now, but I thought Chidima should tell us her story just to
Just a quick one. It was in 2019 when we had the training, the GDD training, and I was recruiting a patient, 35 or so year old young man, and his twin brother brought him to the hospital. He was already blind in one eye. And by the time I checked him, I said, "That's your brother. Please sit down. I need to check your eyes." And the twin brother that brought him, he said, "I don't have any problem with my eyes." And his cups were 0.9. Pressure's very high as well. And I recruited him as well. And both of them had surgery. And it was so bad that this twin brother that felt he didn't have a problem was the one trying to take care of his brother and his family because he was an Okada rider. And he didn't even have his own Okada. He had to borrow from someone, do some runs, get some, daily money, then use it to feed both himself, his brother, and his family. So I think you'll finish up what you did for them.
All of us that came to the mission were so excited when we heard the story about how the about to be blind brother is the one sustaining two families. On borrowed Okada, we decided to buy him an Okada. We bought him a motorbike. But thank you all so much.
Okay, sorry, mine is just a quick question and quick comment. The discussion has been very beautiful and the interventional glaucoma series shows different options that we have. I actually want to speak with the policy makers or policy influencers here in this room in Nigeria, because most of the things you've done is because insurance covers it. That's not so in Nigeria. More than 90% of our patients pay out of pocket. When the patient sits in front of you, you are trying to see what is the best intervention I'm going to give this patient that is going to be a one-off intervention. You don't have the luxury of I'll try several, when this fails, I'll go this. That's what we're facing. And you want to even do SLT, some patients will go for 3 months, they don't have fund, start them on drops until they get the money for just one SLT. So the comment is more towards the policy drivers in this room, how we can significantly increase health insurance penetration in Nigeria. Thank you.
Comment on the chat. Comment on the chat online.
Okay, so thank you very much, Maba. I think in Nigeria, we need to promote this interventional glaucoma because, to be honest, we need to change the mindset of the doctors managing the glaucoma. We need to promote the fact that glaucoma is a surgical disease. All over the world, glaucoma surgeons are one of the busiest ophthalmologists. So we need to develop our own interventional algorithms. From these, we don't have mixed, yes, we can start with SLT, Trabec, repeat Trabec, GDD, and all that. But we have to promote the belief that glaucoma is a surgical disease. Now, if you see cataract, the first thing that comes into your mind is surgery. Then we have to look at glaucoma with that mindset. If you see glaucoma, the first thing that comes should be surgery. That's my opinion.
Okay. You'll be the last, Dr. Nathaniel, give it to him, please. Listen to